ladies and gentlemen. Today is another exciting Saturday. A warm welcome to you on behalf of Mumbai Hematology Group. Today webinar topic is AML, optimizing the treatment goals and role of MRD. I would like to say a big thank you to, my slides are not working, so I'll go off slides. I'd like to have a warm welcome to our program director, none other than Professor Dr. M.B. Agarwal. Sir is an institution in himself and we know him very, very well. He is the one who is responsible for bringing up our knowledge level, our academic level, our clinical acumen during COVID time. It's a race in the field of academics every Saturday and Sunday, and a warm welcome to our guest speaker as well. Last but not the least, all the delegates who have logged in from various parts of the world, almost 13 to 14 countries every Saturday, a warm welcome to each one of you. Over to you, sir.
Thank you, Dr. Manoj. So, good evening to friends on this side of the world, and good morning, good afternoon to everybody from Europe and US. Today's lecture is, as was mentioned, acute myeloblastic leukemia, optimizing the treatment goals and role of MRD. And our guest speaker is Dr. Eunice S. Wang from New York, US. This webinar is brought to you as usual by Mumbai Hematology Group, supported by INTAS and managed by Mice Ideas. I thank Dr. Manoj and his team from INTAS, Mr. Rajesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Eunice Wang from New York, all our discussants who are themselves eminent hematologists and medical oncologists, you participants for sparing your Saturday evening. Tomorrow morning, that is Sunday at 11:30 a.m., we have Dr. Dan Derricks, professor. He's from Belgium and he's going to speak to us on post-transplant lymphoproliferative disorders, a field in which he has worked for the last 30 years. Our discussions today include very important personalities in the field of hematology and hemato-oncology from India. We have Professor Dr. Colonel Prakash Chittalkar from Sir Aurobindo Medical College, Indore, Dr. Sadashivadu Gundeti from Nizam's, Hyderabad, Dr. Anupama Jaggi from London Northwest University Hospitals, NHS Trust, London, Dr. Roshni Pandey from Mahakoshal Hospital, Jabalpur, Dr. Meher Lakshmi from Nizam's, Hyderabad, Dr. Girish Balikai from SDM Medical College, Dharwad, Karnataka, Dr. Stalin Bala from Nizam's, Hyderabad, Dr. Mahadev Swami from Manipal Hospital, Goa, Dr. Rintu Sharma from Dayanand Medical College and Hospital, Ludhiana, Dr. Yashwant Kashyap from AIMS, Raipur, Dr. Ankul Mittal from Mohandai Oswal Hospital, Ludhiana. And now to introduce our guest speaker, Dr. Eunice Wang. She is Chief of the Leukemia Service and Professor of Oncology in the Department of Medicine at Roswell Park Comprehensive Cancer Center. She directs the Roswell Park Hematological Procurement Shared Resource and is physician leader for the Roswell Park Chemotherapy Infusion Center. She earned her medical degree from the Keck University of Southern California School of Medicine and completed internal medicine residency at Yale New Haven Hospital, followed by hematology oncology fellowship training at the Memorial Sloan. She has an active clinical practice caring for the patients of acute leukemia, myeloid malignancies, and other hematological disorders. Her clinical research program is focused on early phase clinical trials of novel therapies, particularly small molecular inhibitors and immunotherapy for acute leukemia and myeloid malignancies. She leads a translational lab investigating the role of marrow microenvironment in AML. She is the prior recipient of an NIH Cancer Clinical Investigator Team Leadership Award and an American Cancer Society Mentored Research Scholar Award. Today, she has authored or co-authored over 150 peer-reviewed clinical and translational research articles in hematological malignancies and mentored over 50 trainees. She's going to lecture on AML, optimizing treatment goals, role of MRD. Thank you so much, and over to her now.
Thank you so much for the opportunity. I am honored to be invited to speak to such a prestigious and eminent crowd of hematologists, oncologists, and colleagues from around the world. If you have any questions, I believe we have time for some question and answer sessions. So the topic of my talk today is optimizing treatment goals and the role of minimal or measurable residual disease in acute myeloid leukemia. Here are my disclosures. Acute myeloid leukemia is a disease that presents many clinical and therapeutical challenges. In our country, this is largely a disease of older adults and is considered very biologically heterogeneous, meaning that it has characterized by many different mutations, karyotype, and surface antigen expression, which make it therapeutically challenging to treat with standard or one-stop approach. It's also a clinically aggressive disease, and in individuals who remain untreated or have disease that does not respond, that overall survival is measured in weeks to maybe a few months. You can see here the biological heterogeneity that we're challenged with when we have any patients with acute myeloid leukemia. You can see that there's no one defining mutation. There is multiple mutations, and half of our patients that present in our country with acute myeloid leukemia are going to have disease that have a normal cytogenetic profile, but have different and diverse mutational patterns. You can see the number of different gene types and classes of mutation. There are mutations occurring in at least 9 different biological pathways and processes in acute myeloid leukemia. So this is just incredibly diverse. To meet this challenge, we have now developed in the United States the availability of multiple targeted therapies. These therapies have really all been developed in the last 5 years. You can see some of them listed here, and these are been tailored to help us manage and deal with both the biological and clinical heterogeneity of the patients that we're facing. So how do we go ahead and select AML therapy? What is our treatment approach? What is our treatment goal? In this algorithm, when I see a patient that has acute myeloid leukemia, the first thing I do is I assess the patient's functional status, their age, how their comorbidities, and I have a discussion with them about their goals of care. Do they want aggressive therapy with a curative intent, possible transplant? Are they frail? They only want palliative approach? And what are the resources available to the facility as well as the patient to accomplish treatment successfully? I also, very importantly, assess the disease. So what type of AML do they have? What is the underlying biology? And can we design our therapy to tailor the specific disease personalized for that patient's clinical status as well as their biological disease? Secondly, based on all of that discussion, the next step is to select a chemotherapy backbone. So do we think that this patient would be eligible for an intensive or high intensity approach, or would they be more a candidate for more palliative or supportive care approaches? So I choose what we call a chemo backbone. And then I determine, based on their AML disease status, whether there is a role for any type of targeted therapy. When we look at targeted therapy for AML, we're looking at the presence and absence of FLT3 mutations, IDH mutations, P53, NMP1, MLL or KMT2A gene rearrangement, and then expression of certain surface antigens, specifically CD33. Next, I want to see if the patient is potentially, after receiving induction chemotherapy, Is this someone who, again, could move forward with a potentially curative allogeneic stem cell transplantation, or are they eligible for maintenance therapy or follow-up therapy to maintain the remission for as long as feasible? So when we think about treatment algorithms or treatment approaches in the current age, as well as in the future, there's two approaches. One is if patients don't have what we call a targetable mutation, then we need to think about using that chemo backbone mutation agnostic chemotherapy to our best advantage. And you can see here highlighted the more intensive approaches, more intensive chemotherapy backbones in yellow, and in blue, some of the less intensive chemo backbones for patients that don't have targetable mutations. We then look at mutation guided targeted therapy. And here I've listed the 4 or 5 mutations that we really are looking at whether we can incorporate targeted therapy for these agents. And I'll go through some of the current approaches to deal with each of these mutational abnormalities, as well as some novel approaches, if we have time at the end, that are on the horizon. So to start with, I'd like to discuss intensive chemotherapy for AML. So these consist of largely cytarabine and anthracycline-based approaches, the standard 7+3. I'll talk about the addition of gemtuzumab or a FLT3 inhibitor to that 7+3 backbone, a novel liposomal formulation of 7+3 that has applicability for specific subsets of AML, and then the development of higher intensity, higher dose or intermediate dose cytarabine, combining it with other purine analog inhibitors, as well as BCL2 inhibition. So from 1973 to 2017, the standard of care, which is largely still the standard of care throughout much of the world, is the 7+3 chemotherapy. And this was actually developed at the institute I work at, Roswell Park Cancer Center, also known as Roswell Park Memorial Institute. In this pivotal paper in 1973, Yates and colleagues described the efficacy and tolerability of cytarabine and daunorubicin in acute myeloid leukemia. And in their initial studies, they demonstrated that younger patients who had intensive chemotherapy achieved long-term remissions, and older patients did not. So do we still use 7+3? Yes, 7+3 remains the standard of care for certain of our patients. Why? Because in those patients who respond to 7+3, we actually have the ability to cure patients. You can see here on the left-hand side that there are favorable cytogenetic abnormalities in version 16 and translocation 821, where over these studies looking at thousands of AML patients, that we can actually cure these patients. If you look at the x-axis, you can see that this x-axis is measured in years. So we have patients that are surviving 5 to 10 years after administration of 7+3 and cytarabine-based consolidation approaches. We also know that certain patients that have normal karyotype but have prognostically favorable mutations such as CBP alpha, IDH2, and an MP1 can also, you can see again, the axis is 10 years, be cured with 7+3 based approaches. So this is something that we still rely upon in the current era. However, can we improve upon 7+3? And we do think in some patients that we can. This drug, gemtuzumab ozogamicin, is an antibody drug conjugate with an antibody against CD33 linked to a DNA damaging agent, chemical. This drug was initially approved in 2000 in the United States and then withdrawn in 2010 due to concerns about toxicity and specifically veno-occlusive disease, which occurred in up to 20 or 30% of patients given a very high dose of gemtuzumab. This drug was reapproved in the United States for use in combination with upfront 7+3 in AML patients characterized with favorable or intermediate cytogenetic or molecular risk disease. You can see here that the addition of gemtuzumab in this randomized trial to standard 7+3 improved event-free survival in these patients. And you can see here that this was at the cost of increased or prolonged platelets, low platelets, as well as a small increase in the veno-occlusive disease. Now, meta-analyses have confirmed these results of this phase 3 trial and demonstrated that the addition of GO to 7+3 in patients with favorable and intermediate risk can improve overall survival. You can see a 20% improvement in overall survival in the favorable risk cytogenetic group and about a 6% improvement in overall survival in the intermediate group patients going out 5 years after therapy. Adverse cytogenetics or mutational profile disease does not benefit from this therapy. We now know that FLT3 mutations are found in 25 to 37% of newly diagnosed cases of AML. These mutations consist of mutations in the internal tandem duplication, as well as the tyrosine kinase domains. You can see here the results of the ratified trial, where a multi-kinase inhibitor, midostaurin, which blocks mutant FLT3 in patients with AML, can improve the outcome and overall survival of patients receiving 7+3. This is reflected in the 7.2% difference in 4-year overall survival shown here on the right-hand side. However, we now have newer generation FLT3 tyrosine kinase inhibitors, and you can see them listed here. These newer generation tyrosine kinase inhibitors were specifically developed for the fact that they have markedly improved specificity and sensitivity for inhibition of FLT3 and have little interactions with other tyrosine kinases that could be causing adverse events in administration of these agents. You can see here that incorporation of these newer generation, more potent and specific FLT3 inhibitors has improved the overall response rate reflected by the CR/CRi rate by about 20 to 25, 28% over that seen with midostaurin. Long-term overall survival data with these newer generation FLT3 inhibitors in combination with 7+3 is still underway, but you can see early signs that the incorporation or use of a more potent newer generation FLT3 inhibitor could lead to improved overall survival. You can see here 2-year follow-up with gilteritinib and 7+3 appears to lead to about a 70 to 80% overall survival, which compared to historical data would represent a market improvement. Because of the efficacy of FLT3 inhibitors and their incorporation into the care of patients with AML, in recent proposals for updated AML classification may be considering listing FLT3 mutant disease as intermediate risk and no longer as an adverse risk prognosticator. There's early data presented in a press release format suggesting that quizartinib, another second-generation inhibitor, which has specificity only against FLT3 ITD mutations, when added to standard intensive chemotherapy, can statistically significantly improve overall survival over 7+3 alone. These data are planned to be presented later this year, and so we will look forward to getting additional details. If this data is validated in the peer review setting, this would represent potentially a new standard of care for FLT3 mutant patients in the near future. Now, not everybody has disease that can respond well to 7+3. As we saw, patients who have complex karyotype don't necessarily benefit from GO added to 7+3. We know that patients with complex karyotype or some of these abnormalities do not respond to 7+3 alone. And many of these patients have disease that is emanating from an antecedent hematologic disorder, specifically myelodysplastic syndrome in our older patients. So you can see here that we have defined an entity called AML with MDS-related changes, characterized by both either a clinical history of MDS, or by the presence of some of these all very poor prognostic cytogenetic abnormalities. We also are increasingly seeing in this country evidence of therapy-related AML, patients receiving lines of therapy for their solid tumor, their lymphoma and myeloma, and who are developing at an increasing rate or incidence every year, secondary or therapy-related AMLs from their prior exposures. For these patients who do not benefit seemingly from 7+3, there is a new liposomal formulation of cytarabine and daunorubicin shown here, CPX-351. This is actually just an encapsulated version of cytarabine and daunorubicin fixed within a lipid biolayer. These agents are bound together by a copper entity, which allows them to be delivered at a fixed 5:1 molar ratio, and for these drug to be persistent in the bone marrow for up to 5 to 7 days, as opposed to less than 24 hours with the standard 7+3. In long-term follow-up data, patients who had AML with MDS-related changes or therapy-related AML who received liposomal formulation as opposed to standard 7+3 had markedly improved overall remission rates. And you can see here a 3-year overall survival of 36% versus 23% with 7+3, and a 5-year overall survival of 30% versus less than 20% in those patients getting 7+3. The results were markedly also improved when patients who received upfront therapy underwent subsequent allogeneic stem cell transplantation. And you can see here that patients undergoing that treatment regimen had a 3-year overall survival of almost 60%. Now, what about giving higher dose cytarabine rather than giving continuous 100 to 200 milligrams per meter squared? Can we give higher intensity therapy, 1 to 3 grams? Can we combine other drugs such as purine analogs, cladribine or fludarabine to enhance the activity of cytarabine and include as a supportive care measure growth factors? So many of centers have studied the use of these higher intensity backbones. Here is data presented by the MD Anderson Cancer Group in Texas, US, showing the results of their regimen of a higher intensity fludarabine, cytarabine, GCSF, and idarubicin regimen, combined with the BCL2 inhibitor venetoclax. You can see that this regimen was only able to be given in younger patients. The median age of patients receiving this higher intensity regimen was 44 years. And very few patients were enrolled in their 50s, late 50s and 60s. And the reason for that is because these higher intensity chemo backbones are associated with significant myelosuppression and significant infectious complications. You can see here, even in this patient population with the median age in their 40s, you can see febrile neutropenia, pneumonia, bacteremia, cellulitis, and sepsis were significant grade events in all of these patients. However, you are starting to see with these regimens very, very high reported overall response rates. And you can see here that the MD Anderson group has reported an overall response rate of almost 100% in de novo AML and in the 90% range for patients with secondary or therapy related. So this appears to be more promising than CPX in the same patient population. When they looked at, again, a small number of patients' overall survival, you can see that these patients are about 75% or more are surviving out a year. 2/3 are surviving more than 2 years. However, longer term follow-up on these data are needed, and caution must be taken to realize that these are patients given intensified intensive chemotherapy in an academic medical center, a very small number of patients. However, even these success rates are mitigated by different cytogenetic groups and other the biology of diversity of the disease. You can see here the data for patients that had TP53 mutants, despite the intensity of this approach in combination with venetoclax, a BCL2 inhibitor given for 7 to 14 days. There is no real improvement in patients with P53 mutant disease getting this approach. So patients who undergo upfront induction chemotherapy and consolidation chemotherapy are also eligible at our center for maintenance therapy. And there's currently 2 approved or considered standard maintenance approaches for patients getting intensive chemotherapy. One is oral azacitidine, and the other is FLT3 inhibitor. Now, patients who were getting oral azacitidine were a very select group of patients. You can see here on the clinical trial, which demonstrated the utility of oral azacitidine. Patients were greater than or equal to 55 years of age who had AML or de novo or secondary AML. And these were patients who had either intermediate or poor risk cytogenetics, who are not a candidate for allogeneic stem cell transplantation and were not able to continue and to receive their full induction and consolidation course. So the majority of these patients received upfront chemotherapy and only received 1 to 2 rounds of consolidation before being randomized. Patients were randomized after an incomplete consolidation course to receive oral azacitidine or placebo for 14 days of every month until they had disease progression. All patients were in a morphological CR and had minimal residual or MRD disease measured by flow. You can see here that patients randomized essentially to no therapy did worse than patients randomized to the oral azacitidine, with a median follow-up of over 50 months. There continues to be a survival difference between these two. However, I would say that these curves continue to go down over time, and really, these were patients who were randomized to no maintenance at all. Patients who had evidence of MRD negative disease obviously lived a little bit longer, and patients who had intermediate risk cytogenetics or NPM1 mutation were potentially overrepresented in the long-term survivors. You can see here that NPM1 mutant status at diagnosis was also highly associated with benefit to oral azacitidine. Now, we also offered maintenance therapy with FLT3 tyrosine kinase inhibitors based on the results of this study, where patients who had FLT3 mutant disease were randomized after an allogeneic stem cell transplantation to receive treatment with sorafenib, a first-generation tyrosine kinase inhibitor for FLT3, versus placebo. And again, you see here the relapse-free survival benefit and overall survival benefit to patients with FLT3 mutant disease getting some sort of FLT3 maintenance therapy after transplant. Here is the data with a newer generation inhibitor, gilteritinib, again used after transplant in the relapse refractory setting. And even in relapse patients, this maintenance therapy appeared to be of benefit. Now, the majority of our patients are not going to be able to get intensive chemotherapy. And for these individuals, we typically choose a different, less intensive chemo backbone. You can see here some of the approaches for these patients, and the typical presentation of these would be an older gentleman here, in this case, 70 years of age, who has a preserved performance status of ECOG of 1 and normal organ function, but has evidence of AML with intermediate risk cytogenetics. So in older patients, we are frequently not surprised to know that the majority of our patients who present with this disease are in the older category. And that is because of emerging data demonstrating that as one ages, the rate of clonal hematopoietic mutations occurring in the stem cells within the bone marrow increases exponentially. And this driver mutations or clonal hematopoietic mutations are the primary reason for why we see this big surge of AML in our older patient populations. Now, we know that patients in this older category don't do well with chemotherapy, and we can see here that Although they benefit from treatment over no treatment, their mortality rates of patients in their 70s and 80s with intensive chemotherapy can be as high as 25 to 30%. So we typically, as part of that initial assessment, do determine whether patients should be favored for intensive versus less intensive approaches. And here are some of the factors that we take in consideration as physicians to determine whether patients should receive one versus the other approach. The standard of care for most older patients, mutation agnostic, would be venetoclax azacitidine. The combination of this oral BCL2 inhibitor plus the hypomethylating agents is leading to 2/3 of patients achieving an overall response and prolonged overall survival as compared to administration of the azacitidine alone. You can see that the true complete remission rate for patients is about 37% as opposed to 18% with azacitidine alone. Now, there is some complexity to this data. As we know, this is a very heterogeneous disease. So when we looked at the original study, there are some suggestions of divergent responses based on the underlying biology. You can see here that patients who have TP53 mutant disease appear to have much lower overall response rates, better than azacitidine alone, but not as good as other mutational subsets. And overall survival benefit seems to be questionable in patients with FLT3 mutations and TP53 mutation. We know that patients that have different cytogenetics may respond differently. And there was recent data showing that intermediate risk cytogenetics benefited from venetoclax azacitidine over azacitidine alone in the absence of P53, and that patients who had complex cytogenetics also benefited from 7+3 unless they had a presence again of the P53 mutation. And you can see patients who had the P53 mutation did again markedly worse and did not really have that much improved overall survival versus azacitidine alone. Now, we also know that venetoclax can also be combined with different backbones. Here is data showing the efficacy of venetoclax combined with low-dose cytarabine. This was a more mixed patient population. Many of these patients had secondary disease and received the low-dose cytarabine because they had received prior azacitidine, possibly for MDS. You can see the response rate, 48%, with the low-dose cytarabine backbone plus venetoclax versus 13% with low-dose cytarabine alone. Data suggested that the primary endpoint of overall survival was not met with the initial study. And there's some suggestion that maybe in subsequent post-hoc analysis, there was an overall survival benefit. However, venetoclax low-dose cytarabine is something that I do offer to my patients who've had extensive prior azacitidine exposure, just because I believe it offers a different way of targeting the disease that the patient's cells have not experienced previously. Now, what about patients who are older but might be fit enough to receive venetoclax azacitidine? Should you be giving them venetoclax azacitidine, or should you be giving them this liposomal formulation that I said would improve overall survival in those patients? So this was a retrospective analysis, one of many that was presented at the end of last year. And it looked at real life data in patients who were 60 to 75 years of old, treated at a few different medical centers in the US, and had received either CPX 351 or venetoclax azacitidine. You can see here that there really was no difference in overall response rate with these two regimens, and actually the overall survival looked identical. However, what did benefit these patients was the performance of transplantation. So patients, regardless of what induction chemotherapy, achieved an overall response and went on to subsequent allogeneic transplantation. These were the individuals that survived the best. And there is also data suggesting that in our country that getting to the transplant, regardless of what route you take, is the most important thing. And here is single center data showing the really impressive results of performing transplant after venetoclax azacitidine. So this might be a safer approach to get some of our patients to transplant without exposing them to anthracyclines. What are some of the mutational subsets? What are we using for older unfit patients in addition to venetoclax azacitidine? Is it venetoclax azacitidine or venetoclax for all of our patients, or are there other opportunities? Well, we know that patients who have IDH1 and IDH2 disease respond very nicely to venetoclax azacitidine. You can see here 70 to 78% overall response rates in patients that have IDH1 and IDH2 mutations, and really very prolonged overall survival of over 2 years for patients that have these mutational subsets. However, in our country, we also have the availability of targeted small molecule inhibitors of IDH1 and IDH2 mutant disease in AML. IDH1, IDH2 mutant disease is rare. IDH1 occurs in probably 5 to 8% of newly diagnosed patients. IDH2, slightly more, 10 to 12%. These mutations at diagnosis are mutually exclusive. You can see here that the administration of these oral IDH inhibitors can induce single agent responses in both the de novo and relapse setting, with overall response rates of 40% and true CR rates in the 20% range. This is associated with evidence of differentiation syndrome. Recent data has suggested that combining IDH inhibitors with azacitidine, just like we do venetoclax plus azacitidine, can really improve overall responses. And you can see here 24 months overall survival to patients getting in the upfront setting an IDH inhibitor plus azacitidine versus azacitidine alone. So if those are so good, what about triplet therapy? Can we do venetoclax, azacitidine, and IDH inhibitor? And there is early data saying this is a highly effective approach with newly diagnosed patients, a 92% overall response rate, 83% of patients alive a year or longer. So this warrants additional therapy, an additional follow-up, but triplet therapy with these agents looks effective. Similarly, for IDH2 mutant disease, the combination of an IDH2 inhibitor with azacitidine improves event-free survival in patients with newly diagnosed disease. FLT3 mutant disease also occurs in the older patient population, not as frequently as in younger patients. What about the results, as we mentioned, for azacitidine in these patients? So there continues to be a survival benefit, but for patients that have FLT3 ITD mutant disease, this is not quite as impressive. And you can see here the overlapping survival curves in this retrospective analysis in FLT3 ITD patients receiving ven-aza versus aza alone. This has generated interest in potentially combining a FLT3 inhibitor with azacitidine. And these are the results of a phase 3 trial where patients were randomized to gilteritinib, azacitidine, a newer generation FLT3 inhibitor, versus azacitidine alone. You can see here impressive overall response rates, 58% versus 26%, but no real improvement in overall survival. There was a suggestion that potentially FLT3 ITD patients might have benefited, and these curves look very similar to our retrospective curves. So what about combining a FLT3 inhibitor with venetoclax azacitidine? And this was done in a phase 1 setting in patients with relapse and refractory disease. And this is a very effective regimen, 70, 80, 90, 80% overall response rates, and patients being able to go to allogeneic stem cell transplantation. This approach, although it is very effective in reducing the amount of disease in the bone marrow, really is not associated with that long-term survival benefit in the absence of transplant. So again, what we're looking at in FLT3 mutant disease in the older unfit patient is triplet therapy with FLT3 inhibitor, azacitidine, or decitabine, and venetoclax. Early data, again presented at the MD Anderson Cancer Group in Texas, shows that triplet therapy also can be very effective in this disease. Again, you're starting to see 93% overall response rates versus 70% with a doublet approach, and suggestion that overall and relapse-free survival may be improved with triplet therapy. However, in this academic medical center, you can see that, again, the myelosuppression with this approach remains an issue. You can see that it can take 50 to 60 days to have your neutrophil recovered to greater than 500. And again, 40 to 50 days to have your platelets recover. So this is not a regimen that we can use in the community at this time until we are able to better mitigate this side effect. For patients who are truly frail and are not able to get any myelosuppressive therapy, we are offering treatment with other agents. One of these is Glastagib. This is an oral potent inhibitor of the sonic hedgehog pathway, which is important for maintenance and promotion of leukemic stem cells. The combination of Glastagib plus the low-dose cytarabine backbone has improved overall survival, largely in patients with favorable and intermediate cytogenetics. So this remains an alternative treatment approach. However, overall survival is less than 9 months. Moving onward, how are we improving upon AML therapy? We have all of these agents. We have response rates now 70, 80, 90%. How are we going to determine who's benefiting from therapy, who needs more therapy? How are we going to improve our approaches? So in the old days, when we had overall response rates in older patients of only 20 to 30%, and in certain poor cytogenetic risk groups and 40 to 50%, even in the younger patients, it really wasn't important to measure minimal residual disease because the majority of patients had overt morphological disease. But now that we're increasingly moving towards targeted therapy and different chemo backbones, the ability to measure very low levels of disease is increasingly becoming an important prognostic indicator. So what is MRD, minimal or measurable residual disease? Well, it is residual leukemia that we cannot see by morphology. And typically when we look at a patient to assess remission status, we're looking for count recovery and less than 5% morphological blasts in the bone marrow. However, you can see that microscopic disease detection is really not that accurate. And shown on this graph is just a representation of the amount of residual leukemia in patients. And you can see here that with our treatment approaches, we can get remissions, but many patients are going to relapse. So the goal is really to get what we call deeper responses, to be able to measure disease below the morphological detection. And you can see here that under morphology, there is cytogenetics. And then under cytogenetics are more sensitive measures, including flow cytometry, RT-PCR, next generation sequencing. And the goal of these MRD measurements is to see whether we're getting a truly deep enough response that correlates with prolonged disease-free disease and potentially relapse or versus cure. So the two standard methods to measure MRD are real-time PCR, which detects very low levels of disease, but does require a measurable mutation, or multi-parameter flow cytometry, which is bent on really focusing on looking at the specific antigen expression of the abnormal myeloblast population, and then looking for it again at the time of morphological remission. Next-gen sequencing has also been used, and this has the ability to detect multiple mutations in one patient sample. However, this is not really good for quantitative purposes and also picks up mutations that may be involved in clonal hematopoiesis and not, or germline disposition states that may not be in the malignant clone. Here, shown here is just a table that demonstrates some of the different methods of measuring MRD and AML and the different thresholds. You can see here that cytogenetics has a sensitivity of 5%, FISH 0.2%, flow cytometry down to 0.001%, RT-PCR down to even 1 log below that, as well as next-gen sequencing. Now, when you look at molecular MRD, only about 40 to 50% of AML patients are going to have a mutation that would be amenable for molecular MRD detection by qT-PCR. You can see here that FLT3 ITD is also something that we're looking at in this era. When do we measure MRD in our patients? Well, this is a recent consensus document by the European Leukemia Net, published in December 2021, and it shows you the different AML subtypes that right now are amenable to detection by molecular methods, NPM1, CBBP alpha, and APL, the methods that can be used for MRD in those molecular subsets, and when we would be able to look at these and follow up. You can see that for patients that do not have one of these mutational abnormalities, that flow cytometry remains an option. When is detection of minimal residual disease clinically meaningful? Like, when do we look at potentially changing therapy? Well, it's important to recognize that given the highly effective therapies for NPM1 and CBBP alpha and APL, even though we perform these tests at many time points, typically we would not necessarily change therapy for MRD positivity until they've received a large portion of their treatment course. For patients who are getting flow cytometry for measurement of minimal residual disease, we're usually typically looking at 1 to 2 cycles of induction therapy. Now, what does MRD predict? As we would expect, MRD predicts for overall and disease-free survival. So in this meta-analysis involving 81 different publications in the AML space, you can see here that all of these congregate data suggests that MRD negativity is much associated with much improved outcome as opposed to MRD positivity. This was true for patients that, regardless of the method that you used, if you used next-gen sequencing or PCR or next-gen sequencing, all of these methods had a survival advantage when looked at the results of intensive chemotherapy. So you can see here one of the papers showing the huge difference, almost 50% difference in overall and relapse-free survival in MRD negative NPM1 mutant patients versus MRD positive NPM1 patients evaluated after consolidation chemotherapy. We know flow cytometry can be predictive of relapse. And you can see here a study where they looked at flow cytometry after induction, after consolidation, and after additional consolidation. And at each of these time points, the flow cytometry MRD did predict relapse. What about Ven-Aza? Can we use some of these methods to predict outcome after lower intensity therapy? And this is data showing, even in patients that received venetoclax azacitidine, that the MRD disease status can be associated with improved outcome. What about using one method versus the other? If you have the ability, as some of our academic centers, to do both, that can also improve your predictive power if you use both next-gen or molecular sequencing as well as flow cytometry. Can we do something about the MRD? Or what about maintenance? So this is some data from the original oral azacitidine trial showing that even with oral azacitidine in the maintenance setting, MRD positivity versus negativity was predictive. And importantly, that there were certain patients who responded to oral azacitidine therapy by clearing their MRD. So you can see that patients receiving oral azacitidine had a higher proportion of turning negative with therapy. So this questions whether we can develop therapies to eliminate MRD to prolong survival in these patients. So this is sort of where we measure MRD over the course of intensive chemotherapy, and just some thoughts that this may be the way to target or tailor therapy in patients in the future. So if somebody is MRD negative, they may not need an allogeneic stem cell transplantation? If someone is MRD positive, then can we do something to intervene? And we're going to keep an eye on that patient because we believe that patient may have a worse outcome. Just like to end with just a brief discussion of some novel therapies for AML. And these include menin inhibitors and immunotherapeutic approaches. So we don't have targeted therapies for the majority of AML patients. We have targeted therapies for FLT3, IDH1, IDH2, but we know that there are patients with certain molecular subsets that as of now, we can't target them. So they are falling under the mutation agnostic approaches. Now, there is a novel class of targeted therapies in development, these menin inhibitors, and these menin inhibitors are targeting two biological subsets of AML that we previously have not had any targeted therapy for. And these are patients with rearrangements in the MLL gene or the KMT2A gene, and patients who have NPM1 mutant AML. In both of these patients, there is an aberrant KMT2A or MLL epigenetic complex, and this complex interacts with the DNA, and as shown here, to upregulate HOXA9 and MEIS1 transcription factors driving leukemia differentiation arrest, proliferation, and leukemic stem cell renewal. Now, this KMT2A complex is dependent upon activation with its interaction with the protein menin. So by blocking this menin MLL interaction in both of these diseases, one is able to block or interrupt this leukemiogenesis process. And this leads to downregulation of transcription factors and actually induction of differentiation of myeloblasts. So in early work, these small molecule menin inhibitors have been evaluated in patients with relapse and refractory NPM1 and KMT2A rearranged leukemia. This is data from my first in human study where about 24% of relapse refractory patients with a median of 3 to 7 prior AML therapies achieved a durable response with administration of an oral small molecule menin inhibitor. And on evaluation of these patients, there was, again, as we would hypothesize, proof of principle induction of differentiation in these patients. So menin inhibitors are currently being investigated in a number of clinical trials in the United States and throughout the world. We also have known that immunotherapy has really changed treatment standards for the treatment of patients with lymphoid malignancies, as well as patients with many solid tumor malignancies. What about immunotherapy for AML? And there are a number of approaches under active investigation for this. Studies have looked at anti-PD-1 and PD-L1 antibody therapy that has not been enormously fruitful for AML. There's ongoing data looking at anti-CTLA antibodies, but more therapies are focusing on newer pathways. The CD47 pathway is a pathway that is of much interest for AML therapy. This is a pathway that is involved in macrophage activation. And what happens is expression of CD47 by leukemia cells prevents patient or host macrophages from recognizing phagocytosing and removing cancer cells. So this CD47 is considered what we call a don't eat me signal. It is a signal that is indicating to the cancer cells or the macrophages not to attack the cancer cells. So blocking of the CD47, as you can see here with an antibody, what it does is it restores the ability of the innate macrophage immune system to recognize and remove cancer cells. Overexpression of CD47 is associated with worse prognosis in AML, and treatment of with both azacitidine and a CD47 antibody has resulted in overall response rates in the 60 to 70 range and impressive median overall survival advantage in newly diagnosed unfit patients. You can see here that about half of patients are alive 12 months or more with the combination of a CD47 antibody and azacitidine. And impressively, a number of patients who had TP53 mutant disease had improved survival with this approach as opposed to venetoclax azacitidine. This agent is associated, however, with some side effects, and we know that older or senescent red blood cells can also express CD47. So there is an incidence with the first 1 or 2 doses of hemolytic anemia, and this side effect is currently undergoing increased scrutiny with these agents. There are a number of other agents targeting the CD47 SERP alpha mechanism between cancer cells and macrophages, and shown here are some of the different approaches that are also actively being investigated to improve upon the CD47 antibody and macrophage activation pathway. We also know that there are other immune approaches in development. There are bispecific antibodies, which bind both T cells, CD3 and specific tumor antigens. In AML, these antigens include CD33 as well as CD123 and novel target CLL1. You can see that these same antigens can also be targeted through CAR T cell approaches to genetically reprogram the patient's or healthy donor cells to target AML cells. This bispecific antibody AMG 330 is a CD33/CD3 BiTE, which has been investigated in clinical trial with some eradication of low-level disease and relapse and refractory AML. There is also a CD123 bispecific DART approach, which has been shown to be efficacious in primary refractory AML. And there are multiple companies developing not only autologous CAR T, but also allogeneic CAR T cell for treatments with AML. You can see here that the allogeneic CAR T cells uses a healthy donor to donate cells and have cells genetically modified. The benefit of an allogeneic CAR T is that it's off the shelf and doesn't require time for transfection, et cetera, in patients, and offers a way to provide potentially more healthy, robust T cells for this cellular approach than those in heavily pretreated leukemia patients. So in conclusion, I've just gone through a whirlwind of different approaches, talking about how we select and optimize treatment for patients with AML by assessing the patient and their disease biology, choosing a backbone and or a relevant targeted therapy, and determining whether patients are eligible for transplant versus maintenance therapy. We talked a little bit about some of the mutation agnostic approaches, as well as mutation guided approaches, as well as some of the ways in which we're using minimal residual disease or measurable residual disease to help us with this treatment selection. As well, I've just ended with just a brief insight into some novel therapies that are in development for this disease. So I'd be happy to conclude. Thank you so much for your attention and the opportunity to share these exciting data in the field. And I'm happy to address any questions. Thank you so much.
Thank you so much, Dr. Wang. That was beautiful. So comprehensive and complete update on the subject. We enjoyed listening to you. We have some of the Indian colleagues. I request them to open their videos, and we'll have some discussion now, interactive session. Dr. Stalin already has a raised hand sign. Stalin, go ahead.
Madam, that was an excellent talk, and you enlightened us on AML, so into the very deeper aspects of the AML. So my questions to you are, so if at all we are not doing a transplant, how frequently you do MRD analysis for a patient? So you post-induction, we did an MRD. So if it is negative, still you monitor MRD at a regular intervals. If at all, so how frequently we need to monitor?
So typically we monitor disease in patients every 3 months. Many of the trials look at performing bone marrow biopsies. There are some ways to measure MRD in the peripheral blood, which is obviously much preferable for the patients. What we do is we would measure it in the peripheral blood, and every 3-month interval. After a year or two, we might do it every 6 months. If there's any indication that a patient may have dropping blood counts or the peripheral blood MRD is positive, then we would go forward with a marrow evaluation to confirm the disease. In patients that are negative after 1 or 2 years, we typically do not continue with MRD monitoring at that point, and we would just follow them clinically and with count checks unless there is clinical suspicion of relapse.
At each time when you are doing an MRD analysis, so will you do both methods by flow and PCR, or you stick on to one method and continue to monitor only by that method?
So we typically use mutation, we typically target the mutation for those patients that have measurable disease. Flow cytometry in the peripheral blood is a little bit less reliable. So I reserve flow cytometry really for marrow samples. So for the peripheral blood, I primarily are looking at mutational analyses.
Thank you. Thank you.
Thank you, Stella. We'll take a question from the audience. Dr. Krishna wants to know, when you do TP53 mutation studies upfront, and if it is positive, then can you spare the patient from the intensive chemotherapy?
Yes. So we recently instituted a new molecular panel at our institute where we are looking for FLT3, IDH1, IDH2, P53, NMP1, and a couple other mutations. And we have just this week utilized that assay to help with prognosis. We had an elderly patient, newly diagnosed AML, and we awaited and we didn't think she was a candidate for intensive therapy. And so we performed the P53 mutation to give her and her family an idea of the prognosis and the treatment options for her. If she had P53 mutant disease and she was leaning towards no therapy, then we would be much more supportive of that approach if she was P53 mutant than if she was P53 wild type. So for a patient that says, look, I'm elderly, I don't want therapy, or I'm even not elderly and I don't want therapy, we can say to a patient, you have P53 mutant disease, you're not going to do well. And we tailor our discussion to saying, you don't need an intensive regimen. You may not even need venetoclax. Maybe you could just get away with azacitidine as a palliative approach. So that's an excellent question. And I would encourage those individuals who have the ability to look at P53 upfront to utilize that, because that is a recent addition to our mutation profiling that we did in the past.
Thank you. Dr. Yashwant, your question.
Ma'am, here we are using venetoclax and midostaurin. So what third drug, which is promising, it looks promising, which will probably come to our side also, because most of us are now looking venetoclax and midostaurin in very promising way, and we are using also for our patient. What?
So I think, so your question is, what do you think that, have you tried using a triplet approach or no?
No, regarding what new drug, which will be more, which will improve our patient survival, what newer drug which will come?
So I think venetoclax and midostaurin is probably an appropriate approach for patients with FLT3 mutant disease who are not able to get intensive chemotherapy, such as 7+3. You're replacing the 7+3 with the venetoclax. However, the midostaurin is not the most potent FLT3 inhibitor. It's an early generation multi-kinase inhibitor. So we would recommend, if at all possible, if you had access to a second generation or newer generation FLT3 inhibitor, quizartinib or gilteritinib, that might be more effective for treatment of FLT3 mutant disease than midostaurin. If possible, you may also want to add a hypomethylating agent, because we know that over time, when patients recur who have FLT3 mutant disease, it's very important to repeat the FLT3 mutational status at the time of recurrence, because in the upfront midostaurin 7+3 trials, 50% of patients who had relapse after midostaurin chemotherapy had FLT3 negative disease. So FLT3 is a mechanism of resistance to venetoclax. So it may be good at some point to add in a hypomethylating agent. What might be something that we've thought of doing, or my colleagues and I have done, is to potentially give a venetoclax plus, a FLT3 inhibitor, midostaurin, and then alternate do venetoclax, FLT3 inhibitor, then alternate venetoclax azacitidine, and then go back to FLT3 inhibitor, just to try to deal with the FLT3 negative disease and to prevent that FLT3 negative recurrence.
Thank you, Dr. Yashwant. Dr. Rintu.
Thank you, Dr. Wong, for such an elaborate talk. I have a couple of questions, ma'am, regarding what I have experienced in my clinical practice. So I had a 44-year-old male, favorable risk AML, cytogenetics normal, but NPM1 was mutated. And so he was given 7+3 induction. Post-induction, he had MRD positive, molecular MRD positive with NPM1 positivity. Although the reduction was more than 2 log reduction was there in the NPM1 allele burden. And thereafter, he received 3 consolidations, standard consolidation with high dose cytarabine. And thereafter, after 3 consolidations, his NPM1 molecular MRD was still positive with allele burden of 0.013. So, do you suggest giving oral azacitidine as maintenance in such a patient?
So yes, so I think if you cannot go to an allogeneic stem cell transplant, I think I would give oral azacitidine in that patient, and I would carefully monitor the MRD. And if it turned negative, then I think that would be positive. That would be a positive thing. However, if the patient is younger and able to go to transplant, I think at this point that probably would be the route that would most lead to long-term survival. I think if you can't go to transplant, oral azacitidine is clearly better than nothing. And so I would try one of those 2 approaches. Excellent question.
Unmute yourself, Rintu.
Actually, ma'am, he has some financial constraints. So he cannot go to allogeneic stem cell transplant. But what is the cutoff for you for NPM1 molecular levels of
so the molecular level would be 0.001. So if 0.001 to 0.0001. So I think that patient would still be molecularly positive in our assay.
Yes, yes. Thank you so much.
Thank you, Dr. Rintu. Dr. Roshni.
Good morning, ma'am. Thank you for the excellent talk. As a follow-up to the previous question, there is a situation where you can have low levels of NPM. So in those kind of cases, can one follow up the patients and repeat the MRD, or does one have to be active and proceed to transplant if one has a matched sibling donor?
So I would always advocate, particularly if somebody was negative and then turned positive, right? I would always repeat, if there's a question that you're going to make a therapeutic decision on a patient, the recommendation is to wait and repeat the assay, because you don't want to just transplant somebody based on a false positive, right? So what I would do is I would look at it. Is this clinically suspicious? Are they negative, negative, negative? All of a sudden they're positive. Well, you're not going to transplant somebody just based on that positivity. So I would repeat it. I also would, if it was done in the peripheral blood, I would repeat it in the marrow, because I think that your sensitivity is a little bit better in the marrow. If it is again positive in the marrow, I think that would potentially be an indication to transplant somebody if they could go. But I agree with you. You don't want to just take it at face value. And so I would repeat it. And if it was in the peripheral blood, I would repeat it in the marrow.
Another question is, if you don't have a targetable mutation, do you need to do both flow cytometry and NGS if one didn't have a baseline flow cytometric analysis done?
So the problem is, if you don't have a baseline cytogenetic, a baseline flow cytometry, then then the MRD assay may not be that helpful because you're not going to have a particular phenotype, and AML cells can be very diverse. Some are CD34 positive, some are negative, CD117 positive, negative. They're not all CD33 positive. So you could still run a flow, but knowing that if you don't have the diagnostic flow, that it may not be very specific. It probably would be better than nothing. Because if they did detect something in the abnormal, then that would be suspicious. But the ability to use flow MRD is really really compromised if you don't have the initial flow. So in that situation, if they have a targetable mutational analysis, I would look for that. But it may be that there certainly are patients that don't have a targetable mutation and we don't have an initial flow. And for those, we monitor them the way we always have, unfortunately.
Thank you, ma'am.
Thank you. Dr. Anupama?
Hello, thanks. That was a very nice comprehensive talk. I have some questions related to COVID-19, given the current scenario, because especially in the UK, we are seeing like wave after wave of COVID-19. Did you find that some particular limb of treatment was better tolerated or had better results with infection rates being less, and also what kind of vaccination strategy did yourselves adopt?
Okay, so in terms of COVID-19 therapy or diagnosis and AML, a group of us did provide some treatment guidelines. In the beginning of the pandemic, there was concern that patients should probably be treated outpatient to minimize their going out and potentially being exposed and frequent visits to the treatment centers. What I found is that we had a very restrictive visitor policy in our inpatient unit. So it actually was probably, in my mind, better for the patient to be admitted to the hospital and be in a protected environment with limited visitation and receive the standard upfront therapy in that setting than to go back and forth to the clinic and multiple exposures, just commuting and so forth. Many of our patients who did not want to be admitted because they couldn't have visitors, we treated with venetoclax azacitidine. Certainly for acute leukemia, we don't want to delay therapy, so we do not recommend delaying therapy for AML patients in terms of, but we did, there was interest in potentially more oral therapy or ambulatory therapies. And also because patients, if they weren't going to be admitted, didn't want to travel to the larger centers, we also interacted more frequently with the local doctors to try to see whether they could stay locally rather than come to large cities and be exposed. In terms of our vaccination strategy, we do recommend that the patients get in this country the 2 vaccines, and now we are recommending the 3rd as well as the 4th vaccine booster for those. The booster, it should be given 4 months. If it's been 4 months since the last shot, we are recommending that patients get that booster. But what we also have available now is the ability to give prophylactic antibody therapy to our patients. So even for patients that are vaccinated, because they have a blood malignancy, we have found that they do not make as many antibodies, even with the multiple vaccines and boosters. So if possible, we are giving them prophylactic antibody therapy to provide passive immunity through the antibody. I think that's been probably a better approach than to continually vaccinate people that for various reasons may not develop adequate levels or sustain adequate levels.
Thanks. Thank you.
Thank you. Dr. Yashwant?
Ma'am, continue. Ma'am, you're in COVID positive patient. How was your experience with AZA and venetoclax? In short, some patient.
So we're able to successfully treat those patients, but we would treat them in the inpatient setting. We have in some patients, if they're very sick, they're respiratory compromised, we have, tried to get them out or wait a few days to start therapy if they're having an active COVID pneumonia, they're febrile, they're hypoxic. Certainly we don't want to, we try to mitigate that, give them steroids, antiviral, give them antibody therapy. We hopefully would improve that before starting therapy. But the other thing we realized is because of their impaired immune system, they can test positive for weeks after their initial diagnosis. So if you have a patient that's clinically improving and is still COVID positive, if you try to wait until they technically turn COVID negative, it could be weeks later. They could be looking fine clinically, but they're just never going to clear the antigen to be negative on the test. So as long as they're clinically stable, we have had success in treating them with standard therapy and getting them through that. It's mostly based on their clinical, obviously if they're intubated or they're on 100% oxygen supplementation, then we don't recommend, as with any severe pneumonia, necessarily starting therapy at that time point.
And ma'am, how you treat myeloid sarcoma patients?
So we treat myeloid sarcoma patients with systemic therapy because we know that even though we don't see it in the blood or the bone marrow, that it originated there. So we do not treat those patients unless it's an extremely large lesion that's causing functional problems. So we had a patient that had a myeloid sarcoma in their gut, or we have people that have myeloid sarcomas in their back that's causing spinal cord compromise. For those situations, we radiate to mitigate the immediate problem. And that's also always followed by systemic chemotherapy. Any patient that has a myeloid sarcoma, we also do a PET CT scan at diagnosis to identify other areas that might be involved with that disease. If it's already escaped and gone to one place, it could have gone to some other place. And we always perform a lumbar puncture to look for the presence of central nervous system disease. So those patients, we would stabilize the actual lesion. We don't do local radiation unless there's a benefit to some local control. We do a PET CT and LP, and we start systemic therapy. We tend to lean towards 7+3 based approaches in those individuals. Venetoclax azacitidine in our patients has not been a good strategy to get a CNS, to get disease control for extramedullary disease.
Thank you, Yashwant. One question from the audience. Dr. Rahul wants to know about the maintenance of FLT3 inhibitors. How long do you continue?
So, what we do is we start them on sorafenib maintenance, and in some centers that have the ability to do FLT3 next-gen sequencing for minimal residual disease, patients who turn negative and remain negative after 2 years of FLT3 inhibitor are able to be stopped. If you don't have the ability to monitor FLT3 MRD, then my strategy is to continue them on therapy 2 years or even indefinitely, depending on their tolerability. I would, however, my experience with sorafenib is that it is in the long term can be associated with cardiomyopathy from long-term tyrosine kinase use. So if you are continuing long-term with sorafenib, you will need to monitor their cardiac function carefully with, I would say, annual echocardiograms. And if there's evidence of any cardiomyopathy, then I would stop the agent in the absence of any detectable disease after 2 years.
Thank you. Any difference in the policy for midostaurin?
No, midostaurin is a little bit more difficult. I've had patients. So the question is, do you need to continue 50 milligrams BID for midostaurin? I have a lot of patients that get a lot of GI toxicity, and I have dropped them to 25 milligrams twice a day to try to kind of maintain them on drug. And for patients that can't stay on that dose, I've tried to get a second generation inhibitor. But I have reduced the dose in the maintenance setting to 25 BID.
Thank you. Dr. Indu.
Ma'am, just a very basic question. So do you re-challenge patients who develop grade 2 to grade 3 cerebellar toxicity with hydrocytarabine?
If they have neural toxicity, I don't read challenge. If they have cerebellar, I drop the dose from over a gram to 400 milligrams per meter squared. If they continue to have toxicity, then I move them back to maybe an infusional regimen, a 5+2 regimen, as opposed to just a high dose cytarabine. If it's issues with other, issues other than neurological toxicity, I might try a lower dose. For patients that have favorable risk disease, I will, for consolidation, I will give gemtuzumab plus the high dose cytarabine for 2 cycles out of the 3 to 4 that I plan. If patients are not tolerating the GO plus the HiDAC with cycle 1 and 2, I might omit the GO with cycles 1 and 2 and just give it with cycles 3 and 4 if possible. And then for favorable risk disease, if you're able to do for a younger patient 3 grams per meter squared, sometimes after 3 cycles, if patients are not tolerating, I'll stop after 3 and I won't give 4.
And another question, ma'am, how do you manage a young patient, like 23, 24-year-old patient who of AML standard risk, favorable risk, who presents with extensive perineal abscess with the widespread sepsis with sepsis? So do you treat them with the azacitidine, venetoclax at first, then to give 7+3 induction after the initial acute illness stabilizes, or do you straight away give 7+3 induction under the cover of antibiotics?
So what I would do is, I think it's reasonable if somebody's very ill and you're concerned about giving 7+3 in that setting, to give them broad spectrum antibiotics, manage the sepsis. And I think it is reasonable to sometimes, if they have hyperleukocytosis, give them hydroxyurea or even a single dose of cytarabine to treat the hyperleukocytosis, but not to start the actual regimen of 7+3 until they're more stable. Have we done Ven-Aza in that setting? We have not. We have done a single dose of cytarabine, we've done azacitidine, we've done hydroxyurea. I think it would be potentially reasonable to give venetoclax, but venetoclax needs to be given daily for several days. So I don't think that venetoclax in and of itself is a good immediate cytoreductive therapy. I would favor maybe if they need something, again, giving something like hydroxyurea or azacitidine that's a little less myelosuppressive to control the disease until you can start 7+3.
Thank you so much.
Thank you. Dr. Stalin.
Madam, among the FLT3 inhibitors, we had the availability of only midostaurin. So for a relapsed AML who is not able to tolerate an intensive induction chemotherapy, among the doublets, what can be preferred? So azacitidine and midostaurin combination or azacitidine and venetoclax? We have a targeted therapy. So what is the preferable doublet combination?
So for patients with relapsed and refractory disease that are FLT3 mutant, we think that the triplet approach, which we have used in a few patients, is extremely myelosuppressive. So unless you have the ability to keep that patient in hospital for 50 days, 60 days, triplet, I think, is right now, we don't know the appropriate dosing and administration of triplet. So that's only in clinical trials, unless you're desperate. For the doublet approaches, I would favor venetoclax gilteritinib, because in our experience is you get a high percentage of those patients, 75% or more, will have no evidence of morphologic disease, cytoreduction within 28 days. Okay. However, just because you cytoreduce them does not mean that you've cured the disease. So in a relapsed refractory patient that you have the ability to do a transplant, you want to quickly get them into remission safely and take them to transplant. So we prefer to use Ven-Gilt. We reduce the Gilt to 80 milligrams. And we do maybe venetoclax maybe for 21 days versus 28 days. We keep an eye on the blood counts. But that is our preferred regimen. We don't know how much the hypomethylating agent is adding. So if I had to omit something from the triplet, I would omit the hypomethylating agent.
So we had availability of only midostaurin, madam. We can use a combination of venetoclax and midostaurin.
Yes, so I think somebody else on this phone call was saying they were using venetoclax and midostaurin with some efficacy at their center. We don't use midostaurin as much in the relapse refractory setting because we have the availability of gilteritinib, but certainly I would be interested if people were using venetoclax and midostaurin, what the results of that combination are in the relapse setting. As a single agent, midostaurin is not very effective in the relapse refractory setting. Only the study showed early on that it really only resulted in peripheral blast clearance. So I would be interested in the venetoclax midostaurin data. I don't know if I've seen that, but somebody else on this call was using that regimen and had reported good outcomes.
Thank you.
Thank you. One question from the audience. Dr. Shyam wants to know, a young person with AML, FLT3 positive, CNS relapse, has received FLAG-IDA and triple intrathecal chemotherapy, became MRD negative, and he is now on maintenance triple intrathecal. Is there a role of radiotherapy?
So we do not typically do radiotherapy on top of particularly triple intrathecal because I've had unfortunate instances where I've had life-ending leukoencephalopathy. And this is a 30-year-old. So if you add the radiotherapy unnecessarily, you could create problems that could plague that person for the rest of their life. So I would suggest that these potentially, if you could drop to single or double IT therapy again and not add the radiotherapy if they're in disease control, that potentially would be less toxic to the patient. I also would potentially do an MRI and do some cognitive testing and make sure that the aggressive therapy you've done so far has not caused compromise, and that might again change your timing of when you're going to do the transplant. The best transplant conditioning for a patient like this would be a fully myeloablative conditioning regimen because of the aggressive nature of their disease. Using reduced intensity or haplotransplants, I think, are better used in older patients that cannot undergo safely those transplants otherwise. We know that in patients who are MRD positive or have relapse disease, that the results of reduced intensity and haplo are not ideal.
Thank you. Dr. Roshni?
In an elderly, frail patient who has taken about 3 weeks to recover from sepsis and renal failure, which was due to sepsis, and he has IDH1 mutation positive, but we don't have the inhibitor in India, and he also has monosomy 7. So should we go for Aza-Ven or best
Yes.
supportive care?
I think I would go for Aza-Ven. So patients who are IDH2 mutant who are receiving Aza-N have extremely good prognosis with Ven-based therapy. They can achieve a median overall survival of 2 years or more. So and many people are not using IDH inhibitors, even in the United States, because of the efficacy of Ven-Aza approaches. If the patient is more frail, you could get away with the venetoclax low-dose cytarabine approach, which is a little bit less myelosuppressive and may be more tolerable. In our center, we are able to give the cytarabine, people are able to inject at home, and you do get better tolerability with that patient. It's important to recognize that when you give even Ven-Aza or Ven low-dose cytarabine, that the venetoclax is not renally cleared. You can give venetoclax to people that are on dialysis. There is no renal dose adjustment and there's no renal impairment with that drug. It is cleared through the liver. So we've literally given venetoclax to patients on dialysis, and that's been able to be safely given. You don't have to dose reduce. So I think if the patient can tolerate potentially Ven therapy. The other question is, because this patient is so frail, do you need to give 28 days of Ven? You may not need to give 28 days of Ven. You could potentially get away, what I do in some of these patients, with just giving a couple weeks of venetoclax overlapping, or it may be because this disease is so sensitive to the venetoclax that you don't necessarily need to give the patient 28 days. You could get away with 21 days or even 14 days of ven in combination with either AZA or low-dose cytarabine.
Ma'am, the second question is, in patients presenting with acute myeloid leukemias, should we actually look for a genetic risk? I mean, they
Yeah,
ask
so
whether, the sibling can get it or, their children can get it.
So there is increasing data showing that up to 25% of patients who are presenting with MDS prior to the age 40 or 45 may have a genetic predisposition. So in this country, they are recommending that anybody that has a therapy-related MDS or AML potentially have genetic testing. Patients who have 2 or more family members or have a personal history of 2 or more cancers get tested for genetic inheritance. And we have tested a number of our 20, 30-year-old patients that have just a complex karyotype. Anybody that has a really poor prognosis or complex karyotype, we would be very suspicious that in their 20s or 30s that they might have a genetic component. And that is important because sometimes that has altered our selection of a related versus an unrelated donor. If we suspect that there is a genetic component underlying a germline. And it's also important for other members of the family and for their potential spouses and offspring to know whether there is an inherited risk.
A small question about APML. If a pregnant woman, say in early second trimester comes, what are the drugs which are safe, standard risk? So would we actually add anthracycline with something else, or should we, use, how do we manage the arsenic and the atra?
So I think that once you get past the first trimester, my impression is that most of the organ development has occurred. And so it is safe even to cautiously give other agents starting in the second and third trimester. For somebody that has APML, I would think that the risk of bleeding and coagulopathy threatening her pregnancy probably outweigh the potential side effects of differentiation therapy in that patient. So I would potentially look at that if you're concerned about the differentiation therapy and the patient has very aggressive disease, you could give anthracyclines in that setting, because again, anthracyclines would only retard growth, but hopefully would not in the second semester have any effect on organ development. So you could cautiously give some cytotoxic therapy, including anthracyclines in that setting, cautiously again with the low counts.
And is there any situation where one would advise MTP in acute myeloid leukemia with pregnancy? Any particular situations?
You would recommend what? I'm sorry?
MTP, a medical termination of pregnancy, apart from the first trimester.
I think if there was if you thought that there was DIC or coagulopathy, and you thought that there was no way to control that, and you couldn't, if you had to, if it was a question of you could not control the coagulopathy or the DIC or the disease status, or you couldn't adequately treat the disease, or obviously early in the first trimester, I would potentially, in the first trimester, I think you cannot safely give. And the fetus is very early on. I think I would recommend consideration of termination in that setting. In the second or third, I think in the third trimester, I think I would recommend trying to treat because the patient, and then just working very closely with OBGYN. I think in the second trimester, I think it depends how sick the patient is and whether you think it's feasible, because are you going to be able to give several months of therapy to that patient, right? If you're in the third trimester and you can deliver early, then maybe you only need to do it for several weeks. But if it's going to be like you're going to need to do this for 2 to 3 months, and it's going to be touch and go, I think that's a careful discussion, and with the OBGYN to say, is it able to be carried for that long?
Thank you, ma'am.
Dr. Anupama.
Thanks. Yes, just a point of interest. I was curious to know that do yourselves use decitabine at all in any of the regimens for like fitter older patients, or is it just AZA?
So the initial data with venetoclax used venetoclax azacitidine and venetoclax decitabine. However, the phase 3 trial chose to move forward only with azacitidine. So based on that evidence, I use azacitidine. Do I use decitabine? I'm not sure because we did. I think that some of us have used it because we think it's more myelosuppressive than azacitidine. So in patients that might have a higher white blood cell count, if you're trying to cytoreduce, some of us have used decitabine because we'll get there faster. In the relapse refractory setting, if we're retreating and they got azacitidine in the past, we may use decitabine and we may use a 10-day course. The data up front, newly diagnosed, we do not use decitabine 10-day because there's been recent confirmatory data that 10-day decitabine is not better than 5. And I'm not sure that I would choose 5-day decitabine over azacitidine for any category, including P53 mutant, because I don't see that it's better. And I feel like you have to go with the published data.
Thanks. Thank you.
There's a question from the audience. Is there any place of FAB classification of AML from the angle of treatment in present era?
So that's a really interesting question, because I do think that you would think that as we move towards more targeted mutational approaches that FAB would not be important. But FAB really remains a reflection of the underlying disease biology. So we actually are looking back at FAB. It's interesting for development of some of our therapies. So there, I have a couple of trials which have antibody therapy and have antibodies against myelomonocytic, so M4, M5. So in order to be eligible for those novel antibody therapies that target that biology, you have to have M4, M5 morphology. So I've actually had to go back to my pathologist, and they've actually been arguing now because they don't do FAB. So now there's disagreement among the hematopathologists. Well, this person does have M4, M5, or this person doesn't have M4, M5. There also is some emerging data that patients that have a monocytic differentiation may be more resistant to venetoclax azacitidine therapy than patients that don't have that particular differentiation. So, and we may see with the development of menin inhibitors that there may be certain morphologies that are more sensitive to menin inhibitors. So as we move forward in the field, we also move back. So I think if some of these therapies do, or those predictions end up predicting responses or identifying new targets, we may move back to FAB. So I don't think it's dead quite yet. So stay tuned.
Thank you.
That's an excellent question.
Thanks. Are there any other questions from anybody? Yes, Dr. Yashwant.
Ma'am, my one patient, 73-year lady, frail, so I have good risk. So I have started her on azacitidine. So after 8 months of azacitidine, she was there was no disease. She was in morphological scare, and baseline as MRD was not comparable. So now she's off azacitidine from last 8 months. But now recently she has relapsed. So can I rechallenge, or what I should do? She
got Ven-Aza or she got Aza?
Aza. She has only Aza. She has got.
Okay. So our experience is that if you stop Aza, then they always recur. Okay, number one. I never cured anybody with Aza, but I have kept them alive longer. So you could re-challenge with the Aza. My experience is in general, when you re-challenge, if you do get a response, you may or may not get a response. And if you do get a response, it'll probably be much less than it was before. So that is my personal experience. I've had patients who've wanted to go off therapy. And when they wanted, so I took them off, and then they came back 6 months later, 9 months later, oh, I have relapse. So we restarted it, and we don't always get what we wanted before. So I think it was worth trying. And if you do get restoration of a response, that would be great. I also would, if you have the availability, to repeat her molecular testing to see whether she has maybe an IDH mutation, that it might be worth to try Ven in that setting, or if she had a FLT3 mutation, to try a FLT3 inhibitor. You might want to, just because it's been such a long time, see whether the disease has evolved in some way that might make it also amenable to other therapeutic approaches now that you have some options.
Right. Thank you. Anybody else has a question? Okay, I have 1 or 2 questions for you. Is there any place of autologous transplant in treatment of AML now, today?
At our center, we have not performed an autologous transplant for AML for the last 5 years. Okay, we used to do it as a consolidation approach. Instead of giving people multiple cycles, 3 to 4 cycles of consolidation, some patients would rather do autologous approach. I think now we've really moved away from that. I'm not sure why. I just think that maybe we have more options for consolidation and maintenance, and so people don't want to, or I don't know if it's my transplant group that hasn't been pursuing it. We do consider autologous transplantation right now in the treatment algorithm for AML for patients that have favorable risk disease, that have relapsed. If you can get, because they're so sensitive to the drugs, cytarabine and anthracycline. So the only patient I've done in the last 5 years is somebody that had a relapsed in version 16. I got him back into remission, and I auto transplant him, and he's remained in remission since, but he's the only one. Do you guys do autologous transplant for AML? Do you?
Not much, hardly. Is there anything like venetoclax maintenance?
Yeah, so I think that that's currently being explored in clinical trial, is to use venetoclax maintenance following consolidation for intensive chemotherapy, as well as in the post-transplant setting with or without hypomethylating agents. The only concern that we have with venetoclax maintenance is that when they used venetoclax as monotherapy for relapse and refractory disease, it was pathetic. It was not, as a single agent in relapse refractory disease, the overall response rate was 19%, and probably was more like 10 to 15% if you take out the IDH mutant patients. So in the maintenance setting, not 100% sure whether it would be effective. For us as well, venetoclax is very expensive to get in this country, so we have not been able to use it. So it would be interesting to see the risk benefit of it in the maintenance setting. We're not convinced. I haven't seen any data that would convince me to use that, given the cost at this time.
In NPM mutated patients with a very good result of hypomethylating agent plus venetoclax, can that be used upfront in a patient who would otherwise be eligible for 7+3?
I would not use it. If somebody is eligible for 7+3, you have about a 50 to 60% chance of potentially curing them with 7+3. So I would not, and I think that the results with Ven/Aza are great, but I have never cured anybody with Ven/Aza. So if you had a patient that had the ability with an NPM1 mutation to be cured with maybe 4 or 6 months, 8 months of therapy, versus continuing on Ven/Aza for the rest of their, maybe getting 2 or 3 years, or maybe, longer, I would always choose cure in a fit patient. I think it is reasonable to offer Ven/Aza to people that are not going to be cured with because they're not able to tolerate it. There is a huge debate going on about a young patient with adverse cytogenetics or P53 mutant disease. That patient is not going to benefit from 7+3. Why don't we give that patient Ven/Aza? And there is going to be a phase 3 trial randomizing young adverse risk AML patients to Ven/Aza versus 7+3. But somebody with favorable mutation or cytogenetics, I would not put them on Ven/Aza unless they were unable to get induction. I think that would be taking away the possibility of cure.
Thank you. If a patient has achieved MRD negativity by flow in the bone marrow just by induction 7+3, can you straight go for an allo transplant, or you need to give 1 cycle or 2 cycles of consolidation?
I think it would be fine in that setting to go straight to an allogeneic stem cell transplant. In our facility, I have not, my transplant people cannot do a transplant in 4 to 6 weeks. So we always do at least 1 cycle of consolidation, even if they're MRD negative. But yes, if you have the ability to go to transplant after induction, it would be fine to do that. I just have not been able to motivate my transplant colleagues to do that for our patients.
What is the place of cladribine?
Cladribine. We use cladribine instead of using the FLAG-IDA regimen. It's just a matter of different drugs. We prefer to use cladribine. So we use a CLAG mitoxantrone approach for our relapse refractory patients that have secondary disease, as we feel that that approach might represent a more effective strategy than a standard 7+3. We also have used CLAG-M in the relapse setting as one of our standard reinduction regimens for patients that might be eligible for aggressive reinduction to get them to a transplant sooner rather than later. So I think there is a role of cladribine. I know other centers have used that as their backbone. I think the debate about cladribine goes on and on, whether the MD Anderson group used to use a CLIA regimen, right? They used to use a cladribine, cytarabine as their backbone. And then there was a phase 3 trial showing that it was not better than 7+3. So now they've moved on to FLAG-IDA. So I think all of these agents have activity in the intensive regimen, depending on where you're going to use them. But it's not clear that they're much better than 7+3 for everybody.
Right. Gemtuzumab, can it be used in patient who is in complete remission? Flow is negative, MRD is negative. Is there any place of?
No, I don't think so. And I think that if you're trying to get that person to an allo transplant with a myeloablative, I would not use it because of the increased risk of VOD that we can get with that. And, you know, the problem with using that in the maintenance setting, it does have liver toxicity and it has myelosuppressive effects. So you could have some adverse events in that patient that could affect their long-term outcome and their ability to proceed to transplant.
One question has come up from the audience. Dr. Yen Chin Lin wants to know, long-term azacitidine beyond 2 years, are there any specific toxicities?
I'm not sure if he needs oral azacitidine or oral azacitidine. There is some GI toxicity that supposedly gets better over time if you get different supportive care approaches. Long-term systemic or parental azacitidine, I have given azacitidine for 5, 6, 7 years in some patients. Number one, I've never cured anybody. People still relapse even after all that time. And prolonged azacitidine tends to lead to hypocellular hypoplastic marrows. So as they lose their response, they tend to have a very empty marrow that makes it difficult to retreat them. But those are the major side effects that I've seen. I don't know that we have enough experience with 5 years of oral azacitidine to have the same toxicity. You have to remember that oral azacitidine is only 20 to 30% equivalent to sub-Q or IV. So it's not a one-to-one conversion. Okay. Oral decitabine, which has been approved in our country, is a 97% equivalent to IV decitabine, but oral decitabine is only 20 or 30%. So it may be that the toxicities we see with IV or sub-Q azacitidine long-term might be less so with the oral.
And oral AZA, you use 200 per day or 300 per day?
So oral AZA, I think it's 100 milligrams twice a day. I have not used it very often. I have one patient who was on oral azacitidine, stopped, was MRD negative on oral azacitidine, stopped the oral azacitidine for 3 or 4 months, became MRD positive. So we have put her back on oral azacitidine and waiting to see whether she converts negative again.
Thank you. I think that's all what we have. Dr. Yashwant, do you have any question? No, I don't think so. Okay, you have? Yes, go ahead.
I'm one of my patient as a plus when now he's not keen for IV. Post as a when he is doing well. So in him, I have shifted him on oral. So means till what time? Till progression only will continue that drug.
So he's on oral azacitidine, you said?
Yes, now started because he was not fit for 3+7 induction, and he was TP poor risk. So I have started him on azacitidine with venetoclax. Now post 7-8 months, he is doing fine. So I have he was not keen for IV drug. So I have shifted him on tablet, both tablets. So will that is a okay strategy or?
Yeah, so we don't know. So we know what the best way to use venetoclax is up front. But long term, everybody has this question. What should we do long term? Patients don't want to stay on. They don't want to come to the center. They want to come every 6 weeks, 8 weeks. So we all use different strategies. Some of us stop the ven. Some of us stop the AZA. Some of us do what you do, but some people keep ven and AZA, but they give it every 6 to 8 weeks. I think that you should, I think there's no right answer. I think you should do what is most comfortable or applicable for you or your patient. I do think they should get some sort of therapy. If they're IDH1 or NPM1 mutant, were they NPM1 or IDH at the diagnosis or no, they were not?
He was 50, poor risk TP53. Yeah, positive.
Okay, so if he's TP53 positive, I think that his outcome is probably going to be the same, whether you do AZA alone versus AZA-ven. So I think it's perfectly fine to just do AZA alone. I think because he is P53 mutant, he will relapse at some point. Hopefully you can keep him disease-free, but I agree that you don't need to have the ven for that particular patient. And then how often to do that is sort of, again, up to you logistically for the patient.
Well, Dr. Wang, thank you so much for sparing you such a valuable time. Lecture,
Sure.
long interactive session.
Oh yes, I think we ran over by a little bit, but that's fine. I'm happy to answer all these. I'm so happy to see that there's so much interest and so many interesting questions. Excellent, fascinating questions actually. So I always learn something from the questions as much as everybody may learn or not learn from me.
Thank you so much and have a wonderful day.
Okay, take care. Thank you.